Good morning, and welcome to the 2023 Curtis R. Holzgang Visiting Scholar Lectureship. I'm Kevin Dirksen, Senior Director and the Andy and Bev Hansel Endowed Chair in Applied Healthcare Ethics at the Providence Center for Healthcare Ethics. We're broadcasting live this morning from Providence St. Vincent Medical Center on Teams Live. You can earn continuing education credit for watching either live or recording of this event, which is available via the same link as the invite for today's presentation. I'll be monitoring the Q&A throughout the session, so please do submit your questions and we'll hold them to the end as time permits. The Visiting Scholar Lectureship is a program of Providence Center for Healthcare Ethics named for Dr. Holzgang, Emeritus Faculty, Internal Medicine Residency at Providence St. Vincent Medical Center. During his tenure as Director of Critical Care Medicine, Dr. Holzgang was an inspiration in ethics education, especially for internal medicine residents and nurses working in critical care. He was instrumental in establishing the Providence Center for Healthcare Ethics in 2000. Since that time, the center has become a recognized leader in advancing the importance of ethics in healthcare. I'd like to personally thank Dr. Holzgang for being here with us this morning and his son Mike for joining him as well. Let's thank Dr. Holzgang. And now it is my pleasure to introduce our 2023 Holzgang Visiting Scholar, Dr. Michael McCarthy. Dr. McCarthy is an associate professor and director for the graduate program in healthcare mission leadership at the Neiswanger Institute for Bioethics, Loyola University Chicago Stritch School of Medicine. He received his PhD in theology from Loyola University Chicago, where he developed a social ethic for medical research by drawing on the thought of Ignacio Ellacuria. His interest at the intersection of social ethics in Catholic healthcare led to co-editing with Dr. Therese Lisseau, Catholic Bioethics and Social Justice, the Praxis of U.S. Healthcare in a Globalized World, which received a 2019 Catholic Press Association Award for Catholic Social Thought. In addition to questions of justice and inequality in healthcare, his scholarly publications have focused on spirituality in medicine, medical research in Catholic universities, and the role of formation in medical education. Beyond the classroom and his research, Dr. McCarthy serves as co-director of the Physician's Vocation Program and is a member of the Ethics Committee and serves on the Ethics Consultation Service for Loyola University Health System. And now we come to our topic in Dr. McCarthy's presentation this morning. There is arguably an issue of no greater importance today than how we might widen our gaze to appreciate the range, breadth, and depth of our actions, the service we perform for others, and the work that is left undone. Concepts like right relationship, social solidarity, and the common good have been replaced by a moral tyranny of the me. What I deserve, how I have been treated unfairly, what I have owed to me. As a father of young children, what I sometimes think of as a zero-sum, that's the toy I want, toddler tantrum totalitarianism. This morning, we leave that nonsense behind us and open up our ethics to what we might be if only we could muster the courage to turn ourselves to the we. Let's invite up with a warm welcome our moral Sherpa this morning and see where we might go together. Would you please help me welcome Dr. Michael McCarthy?
Thank you, Kevin, for that warm introduction. Dr. Holzgang and Mike, it's a real pleasure to be here to deliver this lecture. So thank you very much for all you've done for Providence and for having me out. And to Sarah and Kelsey in the back, thank you for all of your organization over the past months to allow me to come. So now Kevin gave this great introduction that now I have to live up to. So I'm going to try and walk a little bit, but not too far from my notes. Otherwise, who knows where this talk will go. So clinical ethics as Catholic social teaching. So what I want to do, and what Therese Lysott and I tried to do in our book, was to bring together people who thought about social inequalities, but thought about them through the lens of how they manifest themselves in our hospital. And when we tend to get clinical ethics consultations, we tend to focus just on the issue that is before us, usually in the ICU, usually at the end of life, and we focus on what are the benefits, what are the burdens for the patient, what do we want as the clinical team to make sure that we focus on what's in the best interest of the patient. They either stay or leave, we make the decision, we move on, we wait for the next one. Behind how that patient got there, or maybe their limited capacity for autonomy, may come from the complexities that brought them to the hospital. Some of the ethical issues may be our complexities in trying to get them discharged safely, which may be difficult to do, especially if they came from an unsafe environment to begin with. So what I want to do in our talk today is really look at how can we think about Catholic social teaching as a hermeneutic, or a way of interpreting some of the clinical ethics issues we see in our everyday situations. So I want to look at a couple of cases that seem like a regular clinical ethics case, maybe a little more complex than some of the other ones that we see, less routine, but still kind of look like, yeah, this could show up in our hospital. But then I want to look at how do we think about the social inequalities that are embedded within these cases. I want to describe Catholic social teaching just as a way to kind of think through and unpack what are the other ethical issues that are involved in the clinical ethics cases, and then think about, step back and kind of reanalyze those cases from a perspective of Catholic social teaching. So we'll start with the first case. So I'll do the first two cases, and then we'll kind of go from there. So Miss V is in the hospital for treatment of asthma and pneumonia. She's 53. She's a 53-year-old woman, came to the United States all alone 11 years ago when war broke out in her former homeland. She works as a housekeeper when she can find employment. She does not speak English well. She had been living with a family who recently asked her to move out because they had another child and no longer have room for her. Her pneumonia is improving, and she is considered medically stable enough to go home. The social worker has found a shelter where she can go, but Miss V does not want to leave the hospital and asks to stay longer. So take 30 seconds. What are the ethical issues that you can kind of see within this case? You don't have to shout them out. That's later. Hold your thoughts. What are the ethical issues that pop out? So case 2. Sorry for the text-heavy slide. Mr. V is a 34-year-old male. Mr. V is brought to the emergency department of an academic medical center after sustaining a gunshot wound to the abdomen by an unknown assailant. The triage nurse immediately identifies him as a victim of violence and subsequently places him on protective restrictions as dictated by hospital policy. His injuries are serious. After surgery, he's left with only 10 centimeters of a small bowel and develops severe short gut syndrome, complete with dependence on TPN. During his recovery, the patient has trouble tolerating the restrictions of hospitalization. He's frequently found trying to leave the floor unsupervised and intermittently non-compliant with his NPO. Prior to his hospitalization, the patient had a stable job, was serving as the primary caregiver for his mother, who suffers from end-stage chronic obstructive pulmonary disease. 3 weeks into his hospitalization, he is transferred from the surgical intensive care unit to a regular hospital ward. His condition is stable, but he still has active medical, he's still stable with multiple medical issues, including electrolyte abnormalities and an elevated white blood cell count. Further complicating the situation, his ill mother passes away while he is still an inpatient. At this point, the patient requests that he be allowed to contact his family so that he can receive information and support in the midst of his grieving. His attending surgeon, who is new to the institution, assumes care for the patient and asks that his protective status be lifted, which is denied. In response, the patient threatens to leave against medical advice, though he is clearly unable to maintain adequate hydration without TPN for a prolonged period of time, thus creating a potentially dangerous situation for himself. Psych is asked to evaluate the patient while he is found to be depressed, and the psychiatry team recommends starting appropriate pharmacotherapy and cognitive behavioral therapy. He is deemed to have the capacity to understand the severity of his injuries and the risks associated with leaving the hospital in his condition. So we'll do the same thing there. That was a little longer case, sorry for that. But I think we get this, right? Patients want to leave AMA. That often triggers warning flags, right? Does the patient have capacity? What are the psych issues? Very similar to some of the issues. So just take another couple of seconds. What are the ethical issues that you see in this case? So I saw Dr. Holzgang whisper over here, I'll call you to Susan. So great. See, we call an ethics consult. That's good. We're worth our money. And so we all know what an ethics consult is, but just in case we don't, it's a set of services provided by an individual or group in response to questions from patients, families, surrogates, healthcare professionals, or other involved parties who seek to resolve uncertainty or conflict regarding value-laden concerns that emerge in healthcare. And there are plenty of issues that are in both. I would say we get a little more value-based concern in the second case than the first one, but we can kind of project some of those values onto the second. Both cases, they came from different, one came from a journal, one came from a book that my colleague edited called Thorny Issues in Clinical Ethics. And the Miss V case came from an issue on talking about complex cases, but especially around social injustice, talking about immigration. Another colleague in the book has a chapter on complex case committees. So both of these, in some sense, are issues that could come up in a complex case committee. So an interdisciplinary team meeting together to figure out why we have this patient who has stayed at our hospital for so long and we can't move them on to the next stage, or why do we have a patient who wants to leave? We have these kind of hospital policies in the second case that is keeping this patient here because it's keeping them safe, but they're ready to leave. Well, now what do we do, right? Susan and I probably aren't going to resolve those by ourselves alone. We would want other input. So they're complex in the sense of they create challenges in the clinic setting, but a lot of those challenges kind of come from outside of the clinic that make these particular cases a little more complex. So there are a couple ways we can go about thinking through this. So we probably are all familiar with Johnson, Siegler, and Wenslade's 4-box approach. So I said we'd get back to I made you take notes, right? What are the ethical issues? So let's go to Miss V's case. What are some of the issues that you jotted down for Miss V's case as far as what are the ethical issues? Let's take their first box, medical. What are the medical issues with Miss V? Yeah, they're fairly resolved. So she had medical issues. She no longer has them. Staying in the hospital is probably her now most burdensome, where she could come up with more medical issues. So yeah, so I think that's great. There aren't a lot of medical issues, and I would say that's important to pay attention to. What about patient preferences? Yes, she's not interested. The Hotel Providence is lovely. She loves the amenities that you have all provided. She's not interested in leaving. Let's talk about the quality of life. We have the amenities she likes, right? This is probably a contextual feature too, right? She's okay with staying here, which probably says something about her quality of life, right? If you have a patient that is really interested in staying at the hospital, it might raise other questions about what does their life look like outside of the hospital. So how would she describe what that quality of life would be, which we don't get a lot from that case as to what her perception of what would a good quality of life leave, which leaves us this big open box in the context where Johnson, Siegler, and Winslade say we should put social questions. So then we get, where is she from? Why did she leave her country of origin? Why won't she go back to her country of origin? And often those don't get brought up, at least with the patient in the middle of the consult. They might get discussed among us, friendly conversation in the room, but they don't tend to be a part of the consult. So that's one area that we'll go back to with Catholic social teaching. So let's talk about the second case. So Mr. V, what are the medical issues that he's facing? It's kind of we have opposite cases, right? Miss V had none. Mr. V has a whole lot of medical issues. What are some of the issues that you're worried about? Yeah, TPN dependency. Great. Yeah, electrolyte instability. Yeah, so follow-up care, right? Gunshot victim, had surgeries, other medical complications. Yeah, grief. So he lost his mother who he was caring for. Yes, sir. Yeah, correct. Yeah, so he has a lot of chronic issues that are medical that don't magically disappear when he decides to leave AMA. What about yeah, right. A big change. How do we think about this in a different context, right? So not only the medical, but the mental, right? That this is a new stage of life that this man's going to have to enter into. What about quality of life? Other than dramatically altered? Yeah, so he's isolated, right? So I think we have these hospital policies that are intended to keep him safe, right? He's a victim of violence. So we kind of cut him off because we're worried who's coming in next. Is there someone else that he could have access to? That is what was the context under which he was shot, right? Right. So quality of life, right? So he came in working, caring for his mom, and now he's going to leave without his mom and with a question of what this new quality of life looks like. Yes, sir. Who's going to pay for? Yeah, right. Right. Who's going to pay? So the context there. Patient preferences. I mean, if he's ready to leave AMA, I think it's pretty clear. He's ready to go, right? That this man he doesn't know what his life is going to look like, but he's ready to try it out. So we often, when we're teaching our students in our program, do clinical ethics. So most of these folks are like yourself that are working in a health system and find themselves doing ethics work and are like, oh, I would like to learn more about what it means to do clinical ethics and take that on at their various institutions. And we get to this part of the consult. So we do consult simulations. So they'll come in, it's like bioethics summer camp. They're on our campus for 3 days. And we say, this is the hardest one, right? So how do you distinguish what we do in a family meeting from a family meeting from an ethics consult? And so we'll say, okay, how can you talk about what are the ethical dimensions of the case that you're dealing with? And we tend to be very comfortable talking about these, right? So we talk about patient preferences. The patient wants to leave. His mother died. but we don't think it's in his best interest to leave, right? This is the conversation that goes on. Or the patient exercising autonomy wants to stay, right? That's fine, but it's not in her best interest to stay. It's not in the hospital's best interest for her to stay because there's no clinically indicated reason for her to stay there. So then, other than we have to get Miss V out of here and we have to keep Mr. V here, what are other ethical options that we can think about as far as getting Mr. V and Miss V taken care of in the best possible way? And how do we explain those? And I think in this situation and in these two cases, that becomes very difficult to do because the complexities of why Miss V and Mr. V are in the hospital to begin with have a lot to do with the social circumstances from which they came and from which they're going to have very difficult time returning to. And so what I want to sit and spend the rest of the time talking about is how can we think about clinical ethics and engage the Catholic social tradition or Catholic social teaching in a way that shines some light on these clinical cases in a different way. And so I won't give you the whole lecture on the Catholic social teaching, but just 1891, Rerum Novarum, it really began with Leo XIII thinking about how the church should engage in questions of workers' rights and unions. That was kind of the initial question of Catholic social teaching. And there have been 13 encyclicals since then, and the latest is Pope Francis's Laudato Si, so focusing on the environment. But the questions that the Catholic social tradition kind of engages are, what does it mean to be an institution committed to addressing the inequalities that exist in our world in a way that is reflective of the Catholic tradition? And so I put this as a circle as a way to think about there are many places in which we can enter the Catholic social tradition. It doesn't always have to be start at human dignity and kind of work your way around. But in each of these cases, we can see where elements of human dignity are at risk. We can talk about the factors that contributed to Mr. and Miss V ending up in the hospital are reflective of challenges of promoting and living out the common good. We think about the preferential option for the poor and vulnerable. How might we reconsider these cases, not from where we meet these people, right, in the clinic with complex social, complex medical needs or a lack of complex medical need, but to really address how did they get here? How do these people have no place to go? What are our rights? What are the patient's rights? And what responsibilities do we share in ensuring that those realities are lived? So subsidiarity talks about how we make decisions at the lowest possible level, closest to those that are most affected by the decisions that are being made. Solidarity. How do we recognize that, how do we recognize that our stories are linked? That the success of Mr. and Miss V are a part of our own individual success and challenges and our hospital narrative. How do we develop relationships? So participation and association, right? Often our patients don't have a lot of capacity to actively re-enter the life that they previously lived. How do we allow them to participate? So one of the things that I like to think about when we're talking about social inequalities is not just, is this program successful, but are those who the program is aimed to benefit able to participate more fully? Do they have more choices than maybe they had before? And so how do we develop that? I talked a little bit about this with Rerum Novarum, but the dignity of the worker and labor rights, which was really the foundation of Catholic social teaching. I also mentioned that care for creation and the environment with Laudato Si, peacemaking and nonviolence. We'll come back to that, thinking about Mr. V's story, right? As a victim of a firearm injury, how do we think about peacemaking and nonviolence, especially in communities where violence is a part of the culture? And this element of graciousness, of giving more of ourselves, that would be the way that I think of that. So let's go back to Miss V. So this is just a fancy slide to talk about immigration. We won't go into too much detail. I showed this to my colleague and she said, you can't show them that slide. Don't spend too much time on that. So to Katie Wasson, I promise I will not spend too much time on this slide. But it's a way to explain migration is not simple. We tend to talk about it if we turn on the TV, you just pick a team, right? Or you're pro-immigration or anti-immigration, you're pro-wall, anti-wall. There's not a lot of in between. There's a lot of nuance. In many of these instances of migration, there are factors that we talk about push and pull factors, right? So there are factors that are pushing people from the places that they go, right? Miss V war broke out in her country. So that's the push. There's something attractive about living in the United States, right? So what are the pull factors? What are the social, what are the economic realities? She had no family here, so that was kind of interesting, right? There was no family that she migrated with, right? She was living with family. But what's pulling Miss V here? And so we need to think about that as far as our discharge planning, right? So we can talk about, let's just send her back to wherever she came. And that creates other problems, right? So we need to know the context from which she could. Could she return, and could she return safely? So here's some of the pull factors that are worth thinking about. So she's a house cleaner. So if we look at the US domestic workforce, for immigrants, house cleaner tends to be one of the more prevalent jobs that is occupied by migrants. It also tends to be a low-income job, especially if you're an undocumented immigrant. So already, how did Miss B end up in the hospital? Well, she also tends to access healthcare at a lower rate, only uses it for emergency reasons. So chronic illness, or kind of what turned into a pneumonia, may have been addressed much earlier on if she had access to treatment, if she worked in a job that provided health insurance, or that she had access to treatment. Good on Oregon, because one of the few places that does provide funding, insurance for undocumented children and adults. So in Oregon, we could tell a little different story. In Illinois, where Loyola is, we could tell a different story. In most of the country, Miss V's story probably looks very similar to the one that we heard in that case. So what happened with Miss V? She lived in Oregon, so that was a good start. I think what this case does, if you have access to health insurance, maybe this isn't a clinical consult. Maybe she did have access to have some follow-up, some initial treatment. She didn't access the healthcare services so late in the game, and she was able to be treated. And that is a nice story, but it's not always the one that happens. It also introduces another social issue about housing, right? So not only did Miss V, the question of migration play a role, she didn't have a place to go. So even if you could convince her that she should leave, where does she go? So that isn't covered under the Oregon policy, nor would it be in her case. She's healthy, right? So you have a pretty healthy person who wants to stay in the hospital, but now we have an issue of she doesn't have anywhere to go. So the Catholic social tradition kind of tries to shine some light on these social inequalities that are going to affect the clinical cases that we see. I think one of the issues, and we just read from Dr. Parsi. So he wrote this complex case chapter in the Thorny Issues book, but I think he highlights some of the challenges that affect Miss V in particular. So he says, quote, undocumented immigrants often face a number of barriers when they become patients. When undocumented patients have no place to go, some of these patients will refuse discharge to an appropriate setting in the US. This process, so what often will happen, he says, is that then we bring up the question of medical repatriation, right? Should we just send Miss V back to her country of origin? I would say that's that actually has been pretty well rejected in kind of the ethics literature, that if a patient wants to go back and you have a family or someone to be a point of contact, that could be an option that should be presented to the patient, but that she shouldn't automatically be medically repatriated. It does a lot of things of fomenting distrust within the immigrant community of the health system, right? That becomes another barrier to seek treatment because there is that fear of deportation. And that did happen in Chicago with a case with a patient who was involuntarily repatriated to Mexico, did not have safe and adequate health when he arrived there. That's another lecture of why that was. And he ultimately died. And that happened about the time that a woman who had been living in a hospital for 2 years was repatriated voluntarily back to Poland. And that was a much different story. And I think part of it is that patient willingness to go and really making sure that what's going to happen on the ground, especially with a more ill patient, is worked out. So that's not to say that we couldn't ever send Miss V back to her country of origin, but really being clear about what that option is and that the patient wants that to be an option, because we don't know what the factors are, or we should explore what the factors are that brought her here to begin with. So Mr. V, this is a little more complex, just like his case. So Mr. V is kind of a unique US problem. Firearm injury is prevalent throughout the world. It's not just a problem here, but it is a unique problem when it comes to healthcare here. In 2020, firearm injuries became the leading cause of death for those ages 1 to 19. That represented an 83% increase from when that data was kept in 2013, surpassed motor vehicle crashes, malignant neoplasms, drug overdose, and poisoning. It's then less surprising that about half of adults have kind of experienced some threat with gun violence or with firearm injury. And that's really significant because of this study that came out from Harvard in 2017. And so what this study showed is that firearm injury moves very similarly to a communicable disease. So I'll quote from their study. So 63% of the 11,123 gunshot violence victims, this was in Chicago, during a study period from 2006 to 2014. So give you numbers, but so 7,016 out of 11,123, which works out to 63%, the gun violence victims were attributed to social contagion, meaning that the subject of gun violence, so if we go back to this, right, have seen or been associated with, right, subjects of gun violence were shot on average 125 days after their infector, the person most responsible for exposing the subject to gun violence. So let's take Mr. V. That's people that saw Mr. V get shot. That's like the vector is Mr. V. Anyone that was there present with him, think of it as a sneeze, right? They were exposed potentially to that. So subjects of gun violence were shot on average 125 days after their infector, the person most responsible for exposing the subject to gun violence, with a median time difference of 83 days. So important to pay attention to. From tracing gunshot violence episodes through the network, we detected, so let's take this as Mr. V, 4,107 separate cascades, connected chains of infection through the network. So there were 4,000 of these type incidents, ranging in size, with a single subject cascade that involved 469 subjects. So Mr. V plus one, that's one cascade, with 680 cascades involving multiple subjects and a mean cascade size of 2.7 subjects. So if we take Mr. V's case, Mr. V likely, as a social contagion, exposed people, 2.7 other people were shot after Mr. V who were connected to Mr. V. So these are just kind of some samples that the authors offered to kind of show the complexity and how it spreads. So how do we think about this issue with Mr. V differently? So we can't, it's one thing to say, okay, we have a really complex medical case. And with Mr. V, we do. But what that study says is we have about 2.7 other cases that are 60% likely to follow his case in our general area. So one example of engagement in hospital efforts, so pulling from kind of addressing, thinking about firearm injury as a public health issue and connecting it to Catholic social teaching, has been the role of hospital violence intervention programs. And so I talk, part of, in our book, Teresa and my book, Catholic Social Teaching and Bioethics, we had a group of one physician, 3 public health experts talk about what the connection they see between Catholic hospitals in particular and addressing firearm injury in the community. And so Dr. Byrne and her colleagues write HVIP programs, hospital violence intervention programs, seek to combine brief in-hospital interventions with intensive community-based management after hospital discharge to reduce risk factors for re-injury, cultivate protective factors against it. HVIPs significantly impact the lives of gun violence victims. Program participants have reduced misdemeanor offenses, decreased feelings of aggression, and improved self-efficacy. Additionally, HVIPs successfully decrease both injury and criminal justice recidivism and save costs to institutions. These programs rely on practices of forgiveness, reconciliation, nonviolence, central principles of Catholic social teaching. While HVIPs have demonstrated success and incorporate key aspects of CST, other programs can likewise draw on CST in an effort to interrupt the epidemic of gun violence. So close quote. I think one of the insights that they had in their account, and so Dr. Byrne is an emergency room physician, and she kind of initially approached the chapter of thinking about both the pressure that gun violence victims acutely present to health systems. And I thought I hadn't seen a whole lot about the chronic conditions that also affect the health systems. And then how do we think about a discharge plan as complex as Mr. V's present? So HVIPs are one way to think about some of the services that are going to be needed for a patient like Mr. V. But it does require, and kind of this is the kind of the graph that the CDC puts up to think about firearm injury in the context of public health. Until recently, there has not been a lot of research on firearm injury. So this is a relatively newer area of research, even though victims were kind of prolific. So community engagement is a key piece of this kind of interruption of this. I think if we think of Miss V's case, a lot of that is advocacy, awareness, and developing kind of community resources for migrants. I think here, this is a little more complex because it's not just the social questions of migration and housing, right? Those are things that we've been dealing with for a very long time. I think the complexity of Mr. V is complex medically, it's complex socially, and it's really complex when you're talking about discharging a patient back into the same environment from which they came. And so it needs a lot of trial and error. But the trial and error has to come from partnership, so widespread adoption. I think one of the challenges is this is not going to be a hospital-only solution. It has to be partnerships, talking about subsidiarity, right? Coming from and with the community, right? Not top down, here's the solution, here's how you need to implement, but developing partnerships between the community and the health system. So if the best account that I can give is Mr. V was a former gang member who had left that life behind several years ago. He had a job and was the primary caregiver for his mother until her death. When Mr. V decided to leave AMA, he was able to access much needed mental health care to discuss the loss of his mother, his own recovery, and to have support in his rehabilitation and to adjust his long-term health needs. The hospital, while not wanting him to leave because of his complex physical and social needs, was given permission by Mr. V to inform their community partners of Mr. V's decision to leave AMA and the medical and social circumstances that he would be entering into. I think it's really important to develop community partnerships. This is Greg Boyle, who's a Jesuit priest that works in LA and is the founder. He would not call himself the founder, but works with Homeboy Industries. And so Homeboy Industries is a community-based organization that really, he says, initially I started off with nothing stops a bullet like a job. And he says I cringe. So I quoted that, and then I also read that he says I cringe every time that I hear that said, right? Because it's not as simple as that, right? That he talks about radical compassion. And so how do we care for people once they've been discharged? This is another organization that's in Denver that works with youth. So not just trying to work with those who are already victims or people like Mr. V, right? So who did have a past as a gang member, had left that life, was working, yet still always worried that that life was just behind him. So how do you help kids before they get to that stage to kind of think through some of the decisions and hopefully put them in a better instance of success? Both of these have kind of health aspects to their work. So it's not just jobs, right? It's also, how do you have partners to know where people are going to make sure they have the complexity of services that are needed to engage, to help them live a successful life. So if we think about Catholic social teaching, there's a reason that I said at the beginning that it's not often brought up in clinical ethics consults, because we can't quite work in all of that in our nice 1-hour meeting, nor may it be helpful to address those complexities at the time. So I'd say Catholic social teaching, if we're thinking about them in the context of clinical ethics, is much more of an upstream ethic. So we have to think about the patients that we see, and especially our complex patients, either the ones that we can't get to stay or the ones that we can't get to leave. What are the social factors that are contributing to those complexities? Often they are the social context from which these patients come. And so in Miss V's case, it may be 11 years ago, why did she leave to begin with? And why won't she go home? Or can we even revisit that, right? Are there questions about maybe we could send her home? For Mr. V, right? It's not just the ethical issue of his complex medical care. It's the likelihood that he doesn't have the mental health services or the rehab necessary when he leaves the hospital to begin with. So how do we talk about what do our hospitals, how can we partner with different community organizations or fund community organizations in a way that helps support our patients and ultimately allow them a better opportunity to re-enter the world, hopefully in a safer space. And finally, a CST approach considers what social issues affect patient care and how to respond in a way that sees the hospital as a partner with the community. And I think that requires a lot of our own conversation. So what I'd like to leave with us today to think about is Catholic social teaching is a broad area that has many different points of entry in which we can enter into this conversation. And firearm injury and immigration questions are not apolitical, but neither is the Catholic social tradition. And while some of these issues may present as partisan talking points, Catholic social teaching offers a variety of places to consider how we can address these social inequalities and social concerns of both, in this instance of Mr. V and Miss V, of firearm and immigration, and think about them in a way that exists beyond kind of a partisan divide, but affects real people that we encounter every day in our hospital. CST wants to invite us, and I invite us in our conversation to think about where can I as an individual and where can we as a system think about Catholic social teaching in a way that makes our organization better, but also ultimately will benefit the patients that we serve. Thank you.
So our group online is not quite chatty yet, so we're going to rely on the folks in the room to kind of spin off some dialogue here and get the folks online engaged. But I think this question, maybe to begin with, where can we as an individual or as healthcare professionals enter the system? I'm really interested if Dr. McCarthy's question went out to all of you. Where do you see us potentially entering the circle, or where do you see you and your teams potentially starting to think about these issues in the care that you're providing with a little bit added vocabulary, more rigor, more impact? Any thoughts?
Yeah, I'd just like to say, and you pointed out that the history, a complete history, is so important in a couple of ways, and not just in ethical issues, but in diagnostic issues and such. But that takes time, and in today's world, I guess it's I'm not too familiar with it, but that isn't available. But before any of this decision making can occur, you had to know all of the details. Now, two things occur there. It gives you a better picture from which to make ethical decisions, and it makes a bond between you and the patient if done appropriately, and the patient being much more likely to trust you and have conversations that may be fruitful.
Yeah, no, thank you for that. And I think each of these cases, the other thing that's interesting, I think, about both of them is their histories are different. And we're more sympathetic, I think, to Mr. V's history than we are to Miss V's, because there's nothing medically wrong, right? I can hear in a consult, right, but she won't leave, right? But we just want to get her to leave. And I think, to your point, Dr. Holzgang, how do we, part of it, can we step back from that and say, but we don't have many patients like that, right? So what else is going on with this patient? Or what else can we do for her to help her make the decision to see leaving as an option, right? That may be one of the challenges, is that she doesn't see leaving as an option, right? She has nowhere to go, and this is working out just fine for her, right? So that, to your point earlier, she's happy being here. So keeping her happy, but also creating other options is good.
Hi, Michael. Good to see you.
Hello, Nick.
I'm wondering if you could comment on what I'm hearing in your talk is an invitation to a different kind of gaze for clinical ethicists, and in particular, when we're, in the debates around what we measure and what we count and how we identify ethical issues, what would be your top 3 recommendations to tracking and monitoring your consult service to know that you're entering into this circle?
Yeah, well, and I would say with Catholic social teaching, this is more upstream. So what are the committees that maybe a clinical ethicist isn't on, that a clinical ethicist might be helpful on, right? So would it be helpful if there's a clinical ethicist, we'll take the hospital violence intervention. If there's an HVIP, is an ethicist on it, right? And thinking about, because we know some of the complex clinical questions that can emerge. So I think that's that's a little information. So I would say, if there are committees that are working, I think the role of the ethics consultant becomes then some committee work, because we have some expertise in what's going on in the clinic, and I don't think there is I mean, if I led you to believe this is not, I don't know that you can blend Catholic social teaching seamlessly into an ethics consult where you're talking about immigration. But I do think we know that we have undocumented patients that are within our health system, and we know the challenges that they face. So in this case, if there's a group working on housing, right? What does that Housing First initiative look like? What are the clinical issues that maybe an ethicist can help think through? So I think I'm giving more committee work. I don't know that it's 3 top things, but I think identifying what are the committees in which a clinical ethicist could contribute, both thinking about it from a clinical ethics standpoint, but also a social ethics standpoint. And I think that's one of the skill sets that ethicists provide, right? Is thinking about things from multiple angles. So I think when we're asked to come to a consult, we're asked to think about it, right, going back to the slide on what are the ethical issues in the case, how do we analyze them? What are the range of options? And what we're asking in this upstream approach would be, what are resulting in some of our more complex cases, and can we prevent them? Because I don't even know that in our own kind of complex case committees, we tend to boil it down to clinical ethics issues of how do we make sure this person leaves and has the care that they need, right? It's all about the medical management. And rarely is there space, especially once the patient's in the hospital, to talk about the social questions. So how can we think more upstream and involve ethicists in thinking about clinical ethics as social ethics? Yes, sir.
Wait for the mic, please.
I originally was an anesthesiologist of the National Health Service in Great Britain. And, cases like the first one here, there was a clinical social worker who was readily available. I don't see that person in America very often.
That's another talk, sir. That's the complexity of our U.S. healthcare system that is a little broken.
I mean, nobody has mentioned perhaps an interview with the family that basically kicked her out.
Mm-hmm.
And why was she kicked out?
Yep.
Just because there was another child. I mean, there are many situations like that where that probably was the main part of her social life.
Correct.
Never mind just the employment aspect.
Yeah.
And yet nobody's addressed that.
No,
And
that's an important. No, it's an important point. And who we would be talking to, right? I can hear our social workers. They're going to be talking to that family. Can you tell me why you can't take your aunt back, or whomever? We'll give her some relation of why can't she come back to you? So I think that's a great point.
So with the immigration that we're dealing with, you bring up I think one of the most critical issues that we're facing today, and we've seen inequality or equality of delivery of healthcare. And when you have 140 countries that are delivering undocumented individuals into the country in a system that's already broken, we have this tension of financial paradigm within which all these things must fit. And so I was looking at my Providence Medicare plan last night, and on the back page, I always get 2 pages of new languages. And when we talk about social workers, we're thinking about how do we get some of these languages that I've never heard of? And how do you deliver appropriate health care, as Dad just mentioned, when you can't even talk to the patient in a way that you could fully understand the cultural and language barriers that that are going to be challenges. So there's a tension between the administration and delivery of this beautiful circle that you've put together. Why don't you address some of the most critical issues that you see at the forefront of healthcare delivery and adhering to equality of delivery?
No, I think our healthcare system is a actually we were talking about this in our department. Mark Kashevsky gave a presentation that we don't have a system in the US. We have a patchwork quilt that has lots of holes through it. And so where some of the complexities come from is we don't have people that are citizens cared for to begin with. And so when we have this issue of kind of acute on chronic problem, right? We have the acute problem of treating people who are citizens who are uninsured or underinsured. And then we add patients like Miss V on top of that. It creates an additional strain on an already strained system. So to answer your question, I mean, how do we prioritize it? I mean, I think we first need to have a comprehensive healthcare structure that exists in our country, which still doesn't exist. And so I think before we can even get to addressing some of the complexities around undocumented immigrant care, I think there needs to be some sort of recognition that there's a problem with our system that needs to be addressed. I think when we talk about those that are uninsured or underinsured, I think creating social safety net programs like Oregon has done to kind of have at least the basic minimum level of care. So in this case, allowing people to have access to routine care, right? We know that cuts costs of healthcare over the lifetime of a patient, right? So if we can have access to undocumented persons to be able to see a physician when they're sick and not access emergency services, I think that would be one way to kind of cut the costs initially. So it's a brief answer to a very big question. Thanks so much for asking. Yes, sir.
Yeah, thanks. I'm going to dovetail a bit on Mike's question because I think it's an important one. This is a healthcare issue at its core, but it's not just a healthcare issue.
Correct.
It's inherently an economic issue, but it's also inherently a political issue. I mean, the circumstances that set up both of these problems that you presented here are sort of at their root politically based. What do we do about guns in this country? What do we do about immigration in these countries? Just to take the highest level. And to the extent that those are political questions, I know that organizations like the Catholic Church and others try to kind of stay above the political fray. Nobody wants to dive into that with too much conspicuous commitment because that sets them up for all kinds of other issues. But that itself strikes me as an ethical issue. How does an organization like the Catholic Church stay above that political fray when these things are fundamentally issues of human rights and basic human decency?
Yeah. No, I mean, you guys are just coming with the fastballs, so that's good. Yeah, it was. I'm going to take it though. I'm going to stand in there and I'll wait for your next pitch. That I think this is, and that's kind of why I ended with what I did. That politics we tend to think of as partisan, right? You pick, we're very good at teams, as you're on the red team or the blue team, and there is no purple and there is no other option in between. And I think these issues are perfectly red and blue issues, but they're also, as you said, right, human rights issues, right? They're not, there aren't clear answers, but they're, I think, identifying the narratives of people and the complexities that are involved in what is going on. I mean, I think Mr. V's case of, we can demonize a community, a Black community that has violence prevalence in it. But Mr. V is somewhat sympathetic, right? He has a job, he's caring for his mom, he's in the hospital, he lost his mom. That's a narrative that is compelling. It's also a narrative of a person who's a victim of firearm injury. And so I think the more that we can humanize the narratives of migration and those that live in violent communities, the better and maybe the looser, the more open we could be to hearing those narratives that may contradict our political positions, but may resonate more with our religious tradition. So I think Catholic social teaching is political. And I don't mean it's Republican or Democrat. I mean it's political in the sense of what type of city do we want to create, right? If we think of the root of the polis, right, of political, it has to do with what is the city, what is this good city, right? So if we go back to Aristotle, right, part of it is what type of community do we want to create? And when we're thinking about the common good, I'll end here because I see I'm over time. David Hollenbach is a Jesuit ethicist that teaches at Georgetown. And he says, we talk about the common good as if it is some ideal that we're working towards. And he said, the common good is much more basic and much more relational. The common good is about what type of good do we want to create in common together? And how do we collectively identify what that is and work towards it together? So I think with issues like the ones we talked about today, I think it has to do with what type of community do we want to create? And we tend to not start there. We tend to start with policies that ignore the human dimension that the policies will affect. So I think if we can start from that human dimension, I think we'll get much further in creating that common good. Thank you all very much.
So as we draw to a close, thanks each of you for being here and having this conversation. Your homework assignment is to keep talking. Dr. McCarthy, thank you.
Thank you, Kevin.